I'm going to talk about trauma using unusually flat technical language. Before I start, I want you to know that's a deliberate clinical choice, not indifference. When we strip the emotional charge out of a traumatic event and describe it precisely, we reduce its power over the nervous system. That is the entire method. It is not a way of telling you that what happened to you was small. I'm Dr. Gurpreet Singh Padda, and this is a technical deconstruction of post-traumatic stress and a roadmap out of it. Pain is a signal, not a sentence. It is not a verdict on your future. It's information that your body's terrain has drifted out of balance, and terrain can be changed. The way I run my center is closer to a laboratory than a waiting room. We are recalibrating a nervous system. That means shifting the frame from suffering to technical analysis and deliberate intervention. Three things follow from that, and they're the premises for everything else. Your experience is valid, and it is also measurable. Those aren't intention. Signals that can be measured can be changed, and you are capable of becoming a technician of your own recovery. That's not a slogan. It's a description of the skill set this actually requires. Let me tell you what I think standard care gets wrong. The conventional model defaults to repeating procedures, injections, medications, referrals, largely because insurance permits them. That assembly line ignores the metabolic and nervous system dysregulation that lets pain and trauma become chronic in the first place. And there's a second blind spot. We reserve the word trauma for high magnitude events, combat, assault, catastrophic accident. But in my clinic, trauma is just as often driven by ordinary accumulated stressors, a marriage ending, financial pressure that never lets up, social isolation. The terrain matters as much as the trigger. Two people can experience the same event and only one develops persistent symptoms, and the difference is usually in the terrain, not the event. So we do three things: identify the signal, locate precisely what the nervous system is responding to, fix the terrain, address the metabolic and regulatory environment, measure the change, track it with objective data, not impressions. Now a redefinition, and this is where people sometimes flinch. An aversive stimulus is an event that went against your preferences. Something happened that you wish had not happened. That is deliberately plain. And I want to be explicit. This is not a minimization. It's a technical redefinition designed to hand you back control. When we strip the mystery and the moral weight off a painful event and name it precisely a preference violation, we begin reducing its emotive power over your nervous system. The vaguer and larger a thing remains, the more room it has to operate. This is the first step in what I call behavior reification, converting internal suffering into something observable, measurable, and therefore changeable. Here's how I define trauma in my clinic. I want to flag clearly that this is my operational framework, not the DSM's definition. It's how I make trauma tractable. Trauma is a permanent change of behavior resulting from an aversive stimulus, not the internal feelings, which neither of us can observe or measure. How you act afterward. Behavior is the only measurable unit of trauma. And that definition produces a distinction most people find surprising. Trauma can run in either direction. Positive trauma is behavior change that aligns with your long-term goals. The event pushed you toward becoming more capable, more resilient, more purposeful. That happens, and it's real. Negative trauma is behavior change that runs against your goals, leaving you permanently worse off in how you act, relate, and function. The clinical goal is not to erase the memory. We're not going to do that, and honestly, we shouldn't. The goal is that the behavioral changes it produced stop working against your own stated goals and values. Every generation has tried to make trauma concrete, to anchor mysterious symptoms in something physical and observable. In the 1860s, railway spine, attributed to mechanical concussion of the spinal cord in train accidents. In 1915, shell shock, attributed to artillery concussion in soldiers on the Western Front. In 1980, post-traumatic stress disorder enters the DSM-3 as a formal psychiatric diagnosis, largely driven by Vietnam veterans and the clinicians who refused to let their symptoms be dismissed. In 2013, DSM-5 relocates it into its own category, trauma and stressor-related disorders, separating it from the anxiety disorders. Each era tried to replace the mysterious and stigmatized with something clinical, measurable, and treatable. That trajectory is still running, and this series is part of it. The 2013 revision made one change that matters enormously to patients, and almost nobody outside psychiatry knows about it. DSM-5 removed criterion A2. Under the old rules, to qualify for a PTSD diagnosis, you had to have experienced a subjective response of fear, helplessness, or horror at the time of the event. That requirement was removed because subjective response in the moment turned out to be a poor predictor of who develops PTSD later. Think about who that excluded. Soldiers, first responders, medical personnel, and a great many ordinary people who were calm, composed, even stoic during the event, trained to be or simply wired that way, and who went on to develop severe, debilitating behavioral symptoms months afterward. Under the old criteria, their composure counted against them. Diagnosis is now grounded in what you do and how your body reacts, not in how frightened you appeared at the time. That is the science catching up to real human experience. DSM-5 organizes the symptoms into 4 behavioral clusters. This structure is what lets us assess precisely, identify which specific systems are dysregulated so treatment can target them. Cluster B, intrusion. Unwanted nightmares, flashbacks, and intense physiological reactivity to reminders. Cluster C, avoidance. Effortful avoidance of trauma-related thoughts, feelings, places, or people. Cluster D, negative alterations in cognition and mood. Persistent negative beliefs about yourself or the world, emotional numbing, detachment. Cluster E, arousal and reactivity. Hypervigilance, reckless behavior, exaggerated startle, sleep disruption. Notice that all 4 are described in terms of observable behavior. That is what makes them targets. Next video, what's physically happening in a brain running this pattern? The alarm, the map, and the brakes. If you are in crisis, call or text 988Y, the Suicide and Crisis Lifeline in the United States, or go to your nearest emergency department. Padda Institute Center for Interventional Pain Management, 4477 Woodson Road, Suite 100, St. Louis, Missouri, next to Lambert International Airport, 314-481-5000. This is educational content, not medical advice, and not a substitute for evaluation and treatment by a qualified clinician.